Hi, everyone, and welcome to our webinar, CBT and Exposure Techniques That Work. We're so glad that you're here joining us today, and we have a lot of exciting material to cover in the next 2 hours, packed hopefully with practical and powerful methods that you can begin using right away. We'll take a couple questions at the end, and we'll also share some opportunities for you a little bit later in the workshop as well. And first, I want to say that I'm thrilled to be joined by David Burns today. And I imagine that all of you know who David is, but I will just let you know, in addition to being a world-renowned psychiatrist and CBT legend, David is a dear friend and colleague of mine, and I always feel really honored to present with you, David. And David is one of the most influential figures in cognitive therapy and the creator of the team-CBT model that we'll be diving into quite a bit today. And he's also the author of Feeling Good and Feeling Great, and the creator of the Feeling Great app, which you'll have a chance to learn about a little bit more today. And I'll also just tell you a little bit about who we are at Feeling Good Institute. So our mission at Feeling Good Institute is to elevate the practice of therapy so that patients can recover faster and more fully. We train and certify therapists in team-CBT, which is this powerful framework developed by David. And we help therapists walk through kind of a 5-level certification path. I'll also just share with you very briefly our sort of origin story. So Feeling Good Institute was founded by Maor Katz, Angela Crum, and myself. We had all trained with David in team-CBT at Stanford, and back then the only way to learn team-CBT and to learn was to study directly with David, either in this kind of Tuesday group at Stanford, which you often hear people talk about, or going to one of David's intensives kind of around the world. And so we started Feeling Good Institute with this big dream to make David's tools, techniques, and training style more accessible to more therapists without compromising depth or quality. And everything that we do today still reflects that kind of original intention, which is to help therapists to get better so their patients can too. And at Feeling Good Institute, we don't just teach techniques, but we really try to replicate David's training style, which is built on this kind of foundational idea that you only get better through practice and feedback. And it might surprise you to hear this, but experience alone doesn't make therapists better. Doing more therapy sessions doesn't necessarily lead, to more outcomes. Sorry, I just had something else pop up on my screen. Let me make sure that closes. Sorry about that. And so the question is, what does work, right? So learning, practice, getting feedback, practicing again, that's what actually drives change. And that's what we emphasize in all of our trainings. And we'll tell you a little bit more about how we do that, later today. And so I'll also just ask you this kind of thought experiment, which is, we've talked a little bit about how experience alone doesn't lead to better outcomes and that real growth comes from focused learning and practice and feedback. So I'd ask you to think, what would change for you if you had a structure for consistent growth? And would that be worth exploring? And so we'll share with you more at the end of the day today, but we have created a kind of pathway to help therapists learn, practice, and grow and become really kind of experts in this team-CBT model that we'll be sharing with you later today. So what we'll be teaching you is kind of the tip of the iceberg, and if it's exciting to you, we hope that you'll take the next step with us and join us in the fast track program that we've developed. The one other administrative thing I'll cover before we jump into the content today is how to get your CE credit. Many people start asking us this question. So I'm sorry, I don't know how to get rid of this thing that keeps popping up. I'm sorry, I'm gonna try to figure out if I can do that maybe when David's talking in a minute, but how do you get your CE credit? We're gonna drop in the chat box today a mandatory CE survey that you'll need to complete. access the CE survey in the chat box at the end of the webinar. Mike will drop it in just about 5 minutes to the end of the webinar, at the end of our 2-hour webinar. And after you complete the CE survey, you'll get your certificate of completion within 1 week. So you won't get your CE completion today, you'll get it within a week. Make sure that you do complete that CE survey at the end of the workshop today. And if you have any questions, reach out to us at certification@feelinggoodinstitute.com. So now let's kind of tell you a little bit about the framework of team-CBT. This is what's been developed by Dr. Burns. And so the T in team stands for testing. And that means that we teach and we use with our patients measures at the beginning and end of every therapy session, measures of symptoms and also measures of the therapeutic relationship, so that we can track progress over time, hold our patients and ourselves accountable for really bringing about meaningful change. And so we can address alliance ruptures or issues that are coming up in the therapy session right away. And we won't really be teaching you more about the T or testing, but we want you to know that we use this with all of our patients, and it's an important part of doing effective therapy. And the E in team stands for empathy, and that means that we have tools and techniques for really connecting with our patients, and especially our difficult to connect with patients, and that we don't just jump in and throw methods at our patients, but we actually are measuring and we're connecting and we're empathizing before moving along, and using kind of powerful CBT methods. And the A in team stands for assessment of resistance. That's that we're working on kind of understanding, articulating, and then melting away resistance to change and boosting motivation. And we'll tell you a little bit about that today. But finally, what we'll be focusing on most today are the methods, the M in team, which stands for methods, and we'll be focusing on cognitive and behavioral methods today. And just to sort of share this slide with you is just we want you to understand that there is this really kind of powerful framework that you can learn and work through to help kind of all of your patients. It's transdiagnostic, and it's not a manual for doing therapy, but rather kind of a framework that all effective therapy includes. So now we'll kind of turn to today's specific topic, which is treating anxiety. And specifically, we'll talk to you today mostly about treating anxiety using exposure and also some cognitive interventions. But we want to make sure you're aware before we start that there are at least 4 important models for anxiety causation and treatment. And David, I'll turn it over to you at this point if you want to just mention the 4 models on this slide and then walk us through kind of what each of the models are about on the next few slides.
Yeah, sure. These are 4 really powerful models for understanding and treating anxiety. And the motivational model focuses on resistance. And there's 2 kinds of resistance that all anxious patients will have. And we'll talk about that in just a moment. The cognitive model stresses that all anxiety results from distorted thoughts, and that it's impossible to change without challenging and crushing those distorted thoughts. The exposure model is quite different, and it says all this other stuff is a bunch of crap, and the cause of all anxiety is avoidance, and the cure is exposure. And exposure always works, and everything else never works. And then there's the hidden emotion model, and this states that niceness is the actual cause of anxiety, and an important, powerful tool is that the bringing suppressed feelings to conscious awareness and expressing them and dealing with them. If we'll go to the next slide, I'll just give a slight expansion on these things. The motivational model talks about 2 types of resistance: outcome resistance, which means that the anxious patient comes wanting treatment for OCD or a phobia or social anxiety, but that he or she will actually, or they will actually resist a positive outcome. And this is because of magical thinking in most cases. They think that my anxiety is painful, but it's protecting me, it's helping me. And if my anxiety went away, some catastrophe would occur. Process resistance is that the patient might really want recovery from anxiety, but is unwilling or very reluctant to participate in the process, the thing that they'll have to do to recover, which in anxiety is exposure. And exposure is not the only treatment for anxiety, as some of the early, exposure therapists were claiming, but it is mandatory for every patient to include exposure in the treatment package. And then the cognitive model focuses on distorted thoughts, and there's four types of cognitive distortion from my list of 10 basic ones that are always present in anxiety. One is fortune telling, and that's predicting that something terrible is going to happen. And it's impossible to feel anxious without fortune telling. It's also impossible to feel hopeless without fortune telling. And mind reading, of course, is the idea that you know how other people are thinking and feeling about you. And that's usually not the case. But this is very common in social anxiety when the patient is thinking, oh my gosh, everyone here is confident and no one, they could all see how anxious I am and no one would be interested in me or my life or what I have to say. Magnification and minimization is, I also call it the binocular trick. It's when you blow things way out of proportion. And, patients with panic attacks that you'll see in just a few moments are saying, oh my gosh, I'm on the verge of dying, or I'm about to lose control and end up in a psychotic episode. And anxious patients also minimize the safety in a situation and their own coping skills. And finally, emotional reasoning is reasoning from how you feel. And I know most of you are familiar with these distortions, but for anxiety, it's, my gosh, I'm feeling anxious, I'm feeling scared, I must be in danger. So the anxious patient might think, oh my gosh, every time I get around an airplane, I get terrified. It must be terrifying to take an airline flight. That's extremely dangerous. I can feel how dangerous it is. And then in the cognitive model, challenging negative thoughts is felt to be the cure for anxiety. The very moment the patient stops believing the thoughts that trigger the anxiety, in that very instant, the anxiety will disappear. You'll see this on video this morning. The hidden emotion model is one that I created based a little bit on the psychodynamic or psychoanalytic training I had as a psychiatric resident. And that's that if you ask, if you talk to 1,000 anxious patients, you'll find 1,000 extraordinarily nice people. And the idea is that the anxiety-prone patient is afraid of conflict, afraid of displeasing people, and is constantly focused on meeting other people's expectations. And that is actually causes the anxiety, that there's some hidden problem always that the patient isn't telling you about because they've suppressed it and pushed it down under conscious awareness. And the hidden emotion model involves bringing that problem to conscious awareness and expressing the feelings. And this is a super powerful model. It's hard for therapists to get at first because they don't believe it. And it's not occurring with every anxious patient, but it is with a good 60% or 70% of anxious patients. And once you learn how to do it, it gives you another powerful model for treating anxiety. And among these four today, we're primarily going to be focusing on the exposure model. And the exposure model, again, is based on the idea that avoidance is the main cause of anxiety, and avoidance maintains anxiety. And if you've ever struggled with anxiety, you know how overwhelmingly valid this is. If you're afraid of elevators, you avoid elevators, and that avoidance maintains and creates your anxiety. And the exposure model states that exposure is the cure. Now, the cognitive therapists will argue, and you'll see this today, that exposure isn't a cure for anything, and that the reason exposure is effective is because of the cognitive dynamic. In other words, during exposure, the patient suddenly sees that their belief that elevators are dangerous, for example, that sees that it's not true, or the panic attack patient sees it's not true that they're about to die of a heart attack or about to go crazy. And so it's kind of interesting to look at the exposure through these two different lenses, the cognitive model and the exposure model. And they're two very powerful and helpful models for sure. Now, I'm going to give you an example of the overlap between the cognitive and exposure models with a very severe problem. Terri was a woman who came to me for treatment in Philadelphia after 10 years of extreme depression and anxiety. And at the time, I was using a depression and anxiety test, long versions of my depression and anxiety checklists that were scored from 0 to 100. And I think she had a total score of 199 on those two tests. And at the time was by far the most severely depressed and anxious patient I'd ever seen in an outpatient setting. And her problem was she'd been having 5 panic attacks each week. And during the panic attack, she gets tightness in her chest and gets dizzy and develops the belief that she's,
Sorry. I don't know
you
what
know,
happened.
Okay, I thought you were trying to speed me up,
Not at all.
which is
Not at
fine.
all. Please take your time.
And she has the belief that she's about to die of a heart attack or a stroke or pass out, or that she can't breathe properly. She'd been to many ER visits, had been worked up by many cardiologists, pulmonologists. Eventually, they diagnosed panic disorder, and after 5 years, she was referred to psychiatrist, and they treated her with massive doses of just about every known psychiatric drugs, and that didn't work, and psychotherapy didn't work. And she felt not only panicky, but intensely ashamed, demoralized, and hopeless. Now, when I'm working with an anxious patient, I always work with their daily mood log. And you can see here on the slide Terri's daily mood log. And it's the upsetting situation is that she senses a panic attack coming on. Now, again, that's happened to her 5 times every week. And, she gets somatic sensations. And the cognitive model of panic is the misinterpretation of benign physical sensations. And but when she gets upset about something, she hyperventilates subconsciously. She doesn't realize she's doing that. But if you do that, you blow off too much carbon dioxide, and your blood pH changes. And that creates the symptoms of anxiety, the numbness, the tingling of the fingers, the chest feels tight, she gets dizzy. And then all of her feelings, as you can see that she's circled, depressed and terrified and ashamed and inferior, discouraged, embarrassed, and frustrated, are all at 100, the worst a human being can have. And the anger was the only one that wasn't 100, and that was 25. Now, the cognitive model states that the 100% and only cause of these negative feelings are her distorted negative thoughts. And she's telling herself, I can't breathe properly. And she believes that 100. And if any of you right now believe that you couldn't breathe properly, you too would suddenly become panicked. So she believes that 100, and my windpipe is closing off. She believes that 100. If I stand up, I'll pass out. She believes that 100. I'm about to have a heart attack. She believes that 100, and I'm going to die. She believes that 100. Now, on the next slide, you'll see what I call a recovery circle, and this is a cognitive technique. And the thought that she wanted to work on, we're putting in the middle, I'm about to die. And I always think of 5 or 10 or 15 or 20, or in the old days, sometimes 25 or even 35 cognitive techniques. I've learned or developed over 150 techniques now for crushing negative thoughts. And so I put many up there on the recovery circle, and the idea is called fail as fast as you can, that the faster we go through these techniques and fail with them, the quicker we'll get to the one that works. And so over the course of about the first, I'd say 3 or 4 sessions, I tried a good 15 techniques, double standard technique, examine the evidence, downward arrow, hidden emotion, examine the evidence, feared fantasy, identify the distortions, all this kind of thing. But everything was pretty much 0% helpful, not helpful to her. She came back every week with the exact same incredible scores on the depression and anxiety test. And so I told her, Terri, I've used a lot of gentle techniques with you, and they're just not working, which is okay. But next session, I'd like to try one of the most powerful of all of the cognitive techniques for anxiety, called the experimental technique. And what I'd like to do is induce an actual panic attack during the session. And then during the session, I'm going to teach you to do some experiments to test to see if what you're telling yourself is valid. And she said that she thought that was a wonderful idea and got all excited and went home and called in and left a message that she was canceling her next 2 therapy sessions. And I guess she was terrified and was too nice to tell me that I don't want to have a panic attack in your office. And she left a note, a message saying that she wasn't firing me and that I was the best therapist she'd ever had, but does she have to have a panic attack in my office? And she's too terrified to do that. And so we spoke on the phone a couple times, and she finally, I was able to persuade her to come in. I said, we'll have a double session and we'll have plenty of time. And we're here in the hospital. The emergency room is right down the hallway from my office. And I really want you to take a chance. And that's one of the teaching points for today, was that I'd been getting perfect scores on the empathy scale. So I knew she really liked me and trusted me. And that gave me a license to really push her when it comes to exposure, because almost all patients will strenuously resist exposure. And so I had to persuade her, it was pretty forcefully, to come in and try this experimental technique. And so what happened, she came in, and I told her to close her eyes and hyperventilate like that, because I knew she'd start getting the symptoms. And I said, now move your finger when you feel the symptoms coming on. And after about 15 seconds, she wiggled her finger. And then I said, now I'm going to be the voice of your panic attacks. And I'm just like that voice in your head. And I'm telling you that you can't breathe properly and your fingers are tingling and you're about to have a heart attack. And we're going to have to call for the paramedics, and they're giving you oxygen, but even that isn't working. And they're panicking, and can you see the red light on the ambulance going round and round? And this triggered a massive panic attack, and she started sobbing. Now, I just happened to have a video camera in my office, and I had all my patients record on video or audio all their sessions and either watch them or listen to them at home. And she was one who had allowed me to videotape, and that's why I have this actual excerpt from that session, which of course she's given permission for me to show. And we're just going to cut right into the point where I've just induced the panic attack, and she's sobbing, and she starts begging me to stop. Let's see what happens. Oh, by the way, just stop it for just a second. Yeah, and I want you to ask yourself, whether you're a therapist or a general citizen, the 3 questions when you see this video. You're going to see wild fluctuations in her feelings. Ask yourself, first of all, what is causing the fluctuations in her feelings? A second question is that she's begging me to stop. And if you were the therapist, what would you have done? She's stopping, say, please, Dr. Burns, you're going to see this. I can't go on. We must stop. And then what would have been the consequence of stopping or pulling back if you had done that, or the consequence of pushing ahead? And then if you have any, general theories about if she's improving or getting worse during this excerpt from her session, what are the causes of that? What's going on here, to the best of your understanding? Now let's see what happens.
Experiment and find out if it's true that you can't take a deep breath.
My fingers feel numb.
Do they feel numb? That's another symptom of panic and anxiety, and I'm glad that you're allowing yourself to get real anxious. How anxious would you say you are right now, between 0 and 100?
Like 100.
About 100, about maximum right now. Now, if you couldn't breathe right now, why would that be a problem to you?
I feel like I'm gonna die.
What would you die of?
Too.
Lack of oxygen?
And my heart. My chest hurts. My chest hurts so bad.
Mhm.
And this always happens.
Yeah. Now, what are some experiments that we could do to find out if your heart is working properly and if you're able to breathe properly right now?
I don't want this anymore, please. Just
Well, I'm going to ask you to bear with it so you can kind of put an end to this this fear that you have once and for all. Do you think a person who can't breathe would be able to exercise strenuously? Okay, do you think that you could exercise strenuously right now?
and I don't.
Why don't we find out what would be some strenuous exercise that you could do here in the office to find out whether or not you're breathing properly and your heart is working properly? Well, what's the most strenuous exercise you do? Jumping jacks, running in place?
I don't know. I walk and I ride my bicycle.
Yeah, but we can't do that in here unless you have a unicycle or something. Okay, good picture, but I don't think we have one here. What's some exercise you could do right here to test the belief that you can't breathe? How strongly do you believe right now that you can't breathe?
It's getting less.
How strongly did you believe it?
Oh, like 100.
Okay, well, how about just running in place? Would you be willing to do that? You ever do jumping jacks, running in place, push-ups? Not push-ups, yeah, push-ups, running in place, jumping jacks?
I don't know. I'm afraid if I stand up, I'm gonna pass out or something.
Okay, well, let's check that out. See if you can stand up and run in place. Okay, now let's see if you can do some running in place right now. Go ahead.
I really feel dumb.
Well, run. That's okay. I mean, you might have to feel dumb to get well, but it would be worth it, I think, if you got well. See if I can focus this thing on a exercise there.
I feel really dizzy.
Okay, we'll just keep going. Now, how strongly do you believe that you can't breathe if your heart isn't working?
About 70.
You believe 70% that you can't breathe?
I mean, I shouldn't be breathing, having to breathe. It's heavy. It's a little bit of, and I still can't take a deep breath. And I always, it's like.
Can you run more strenuously? Faster? You do aerobics? Do you do exercising? A little bit? See if you can back up just a little bit.
Sorry.
There we go.
My fingers still feel numb.
Okay. How strongly do you believe that you can breathe right now? How strongly do you believe that you can't breathe?
Let's see. I feel better, like 60 that I can.
You believe 60% that you can or cannot?
That I can.
You can breathe.
That I can't.
Can't. Okay, it's down to 60. How about some jumping jacks?
I feel too dizzy.
We'll try some jumping jacks anyway.
Yeah, if I'm not dying, I couldn't.
Well, could you do this if you were dying? This is what you see in emergency rooms, people with heart attacks doing jumping jacks.
No.
Well, keep doing the jumping jacks. I'm sure you'll pass out at any moment.
My hands feel weird.
Yeah. Oops. How strongly do you believe now that you can't breathe?
About 50.
50, it's going down. Just keep up the juice. You've got to keep acting help us down to 0. And we're going to get a 0 out of you for no other reason than fatigue.
I do. I feel a lot better.
Okay, sit down right now then.
And now let's just see what the audience thinks about some of the questions I asked. First of all, there was a massive change in 6 minutes there. That was actually her first recovery after 10 years of failed medical and psychiatric therapy. You know, heart evaluations, lung evaluations, pill after pill. And you can see that her all of her symptoms went to 0. She wasn't just feeling better, but it was totally abolished the system, and she was able to blow all of these negative thoughts out of the water. But what was it about that experience was one question that, you know, why did her feelings go from uncontrollable sobbing to uncontrollable laughter in 6 minutes? What was the healing mechanism? And secondly, how many of you would have backed off if you were the therapist rather than pushed ahead? And what would have been the implications of that? And maybe, Jill, you can check the chat and see if we've got some answers to those questions.
Exactly. Yep. So I have someone, I'll read to you right now. So it seemed really helpful to ask again and again to rate her strength in the belief. Someone proposed, was it that she was distracted from her symptoms? Someone said the exposure led to a shift in her thinking. Someone said because the more you pushed her to do it, she could run and talk, and that helped her realize that she was still alive. You also got some, tell me if you, I was going to put a couple other comments out there, but mostly, so some people said distraction, other people said like change in thinking, realizing she was not dying since she was able to do jumping jacks.
Yeah, I think most of you have it pretty much on target. This distraction is a mildly helpful technique for all negative emotions, but it's very temporary and a weak sister of the 150 techniques I use. I would say it's the least effective, and that was not the reason. But it's great thinking on your part why she had this profound change in her emotions. But it was because when she was doing the jumping jacks, she said, "I wonder if I could do this if I was having a heart attack." And then I said, "Is this what you see in the emergency rooms of hospitals? Patients with massive heart attacks doing jumping jacks next to their gurneys in the emergency room?" And then she started laughing so heavily that she doubled over with laughter. And then when she stood up, I said, "Keep up the jumping jacks. I'm sure you'll pass out at any moment." And then she said, "Oh, hey, I'm feeling a lot better." And then in the session, I repeated that demonstration one more time. I kind of induced a second panic attack with her permission, and just so she could see that it was something she could reproduce. And she again thought she was on the verge of death, and I got her to do the jumping jacks, and then her emotions went all the way to 0. Then she had some questions about what if she gets a panic attack at home, and a few other things that were kind of fun and funny to deal with. But in the interest in time, I'll just say that one question you might have is, did this last? Was this responsible therapy? Because it seems kind of scary, and it definitely takes courage on the part of the patient and courage on the part of the therapist. I knew, of course, that her negative thoughts were distorted and just not possible. It would have been impossible for her to pass out when she stood up because her heart was racing and her blood pressure was elevated. And fainting is associated with a drop in blood pressure and a slowing of the heart. And, everything she's telling herself is just extremely distorted. But it also shows the hypnosis of the patient. She's trying hard to hypnotize me into believing what she's saying and giving up. And if I had given up, it would have torpedoed the treatment. And I've had to call her. That was 35 years ago, or almost 1988. You can calculate the years, and 40 years anyway. And I call her every year or two to say, how are you doing? And she says, tell your audiences, and can I show this? Because she was so ashamed initially. And she said, I hope you show it to everyone in the United States, and just tell them that I'm still doing great. And she had another child, and which was one of her goals, because they had 4 children, and the previous psychiatrist said she couldn't become pregnant because of all the psychiatric drugs she was on. So he said they might cause a birth malformation, but she was able to go off of all of those drugs and had only one panic attack in the last 35 years. And she called me for an emergency. It was years after this. And I said, well, do your jumping jacks. And I'm doing a workshop today. I just showed this video at a workshop. And then she called and with an emergency. And I said, I'll be home tonight and I can see you tomorrow. And then she called again at the end of the day and said, cancel the appointment. I did my jumping jacks and I started laughing again, and my panic attack disappeared. But anyway, that's a thumbnail of that should teach you a great deal about the cognitive model and exposure. And the question is, was it the exposure or the change in her belief and her negative thoughts that triggered the sudden change in her feelings? And I would argue that in this case, in many cases, the reason the exposure worked was because she suddenly realized the nonsense of what she'd been telling herself.
And David, just wanted to point out, lots of people brought up some things that we will be talking about throughout the day today, which is, people saying, oh, I would have given up because I would have been anxious, and also people realizing if I had given up, I would have perpetuated her belief that she was unsafe,
Right.
another failed
Yeah,
therapy.
yeah. If I'd stopped, she would have said, even my doctor, who's a medical doctor, is frightened. This must be a real thing. So by backing off, which, we're all tempted to do, it would have been horribly destructive for her.
Yep, exactly. So yeah, it's a lot of people realizing that, people also saying, wow, that's amazing, you're so brave, and also commenting on your sense of humor being a part of what was effective as well, which I think is really true. And
Yeah,
also,
just to comment briefly on that, the Buddhists have a form of enlightenment called laughing enlightenment. And that's when you finally confront the monster that's been ruining your life and all of your previous reincarnations. You discover that the monster has no teeth, and you go into uncontrollable laughter and then go to nirvana or some kind of Buddhist heaven. And that's exactly what Terri was experiencing, was laughing and enlightenment. And I use a lot of humor in my therapy.
yes, and I'll also just tell people, if you have questions for us throughout the webinar, we won't be looking at the chat, but Mike Christensen is helping us. And so if you do send questions about the content or questions about exposure in the chat box, Mike will be compiling them. And at the end of the 2-hour webinar, we'll go through some of your questions. We'll have a chance to answer some, although probably not all of your questions. So we've got a lot to cover here. I think you probably covered this, David, but is there anything else you wanted to say?
Well, I just think that some of the teaching points is that thoughts are the cause of negative feelings, and that when you're upset, generally your thoughts will be greatly distorted, as hers were, and that recovery can happen rapidly at the very moment you stop believing those thoughts. And the way you find the technique that works is by failing as fast as you can. And also, patients will fear and resist exposure. She was begging me to stop. And, you know, the consequences of stopping would have been catastrophic. But exposure requires strong empathy and trust. The empathy alone won't do her any good. I was getting perfect empathy score for several weeks before we did this, but her symptoms didn't change. Empathy is not curative for anything, but if without it, you can't go on to the powerful techniques that will cure the patient. And the reverse hypnosis is what you'll be telling yourself as a therapist. You know, the patient will be convincing you, oh, my patient is too fragile for exposure. What if I re-traumatize him and her? And I saw a lot of people talking about, oh, is David going to re-traumatize her? And you know, this is so terribly dangerous, and it's responsible to think about those things for sure, but not get trapped by them. And you know, some therapists might think, well, what if my patient acts out violently or attempts suicide? These are some of the consequences of reverse hypnosis.
And so we'll do a quick poll here with you guys just to understand. Some of you answered this, but we'll do it in the version of a poll so you can all actually answer. So the first question on the poll is, would you have been tempted to back off when Terri begged David to stop? So go ahead and answer that. Yes, no, or maybe, but try and answer yes or no. The second question on the poll is, do you fear and resist using exposure with your patients? So if you're a therapist, are you fearing and avoiding exposure? So either kind of, yes, I avoid exposure. No, I don't avoid it, meaning I use it happily, or I sometimes avoid it due to my own fear. And the last one, since we're all human here, and some of you are not therapists, just members of the general public, but also as therapists, we all have fears. So do you fear and resist using exposure with yourself, whether you're a therapist or a patient? Kind of, yes, I do. Avoid exposure, no, I don't. Or a kind of, I sometimes do. And I'm going to give you guys another 10 seconds, let's say, to answer quickly. Try to get maximal participation here in the poll, and then I'll end the poll and share the results. Okay. So we can see 50% of you said I would have backed off when Terri was begging David to stop. And we have, let's say, do you fear and avoid using exposure with your patients? We have 16% yes, I do, and kind of 47% saying sometimes I avoid, right? So only about 39, or let's say 40% of therapists saying I never avoid using exposure. I'm kind of confident in using exposure, right? So 60% still needing to be convinced. And then do you avoid it yourself? Again, we've got just let's say 30% saying I don't avoid, and the rest saying either I do or I sometimes do.
So I think the poll was great in showing that a lot of patients and therapists alike are really fearful of exposure and avoid using it.
Absolutely. And so hopefully we're going to help you to feel less afraid of using exposure with your patients and with yourself, and also give you some tools and techniques to actually make exposure more effective. But yeah, our take-home message so far is that exposure can be incredibly powerful, as you could see in the video, but also can be really challenging for patients and therapists alike. And we've talked a little bit about this, but some of the keys for successful exposure are empathy, right? Some of you commented that in the chat box as well, that Terri must have had an immense amount of trust in David. Also, a skillful assessment of resistance. David, I don't know if you want to comment on that as it relates to Terri.
Well, there are the two forms. There's outcome and process resistance, and you have to do those before you go into any method. That's the key to team therapy. First of all, you got to get an A or an A+ on empathy, and then you've got to have skillful. The outcome resistance is that if I lose my anxiety, something terrible is going to happen. You know, I'm suffering, but I need this anxiety, or I'll flunk out of college, or you know, and
In the case of a panic attack, quite often that outcome resistance is if I'm not hypervigilant, then maybe something bad really will happen.
yeah, exactly. I need this anxiety, or I'm going to have a heart attack.
Exactly.
I have to sit here motionless, type of thing.
Right.
And then, of course, the process resistance is the very intense and totally understandable resistance to exposure, and the patient and therapist get involved in a folie à deux. In other words, an insanity shared by patient and the therapist that somehow exposure is highly dangerous and needs to be avoided. And that you have to really persist when the patient resists during actual exposure. Terri begged me to stop. And therapist confidence, your self-confidence, your persistence is the crucial key to success. And the patient's resistance is not just for panic attacks, it's for every single type of exposure. That one, you come to the point that the social anxiety, you want them to smile and say hello to strangers. You can go out with them doing this, and they're going to, stop and resist, and you're going to have to push them. And that's where you need the trust and the empathy so you can push them. And you have to have the determination with yourself that you are going to push them. And if you're the kind of therapist who just thinks that, support and talking are the key to therapy, you're going to have a lot of long-term patients, but you're not going to have a lot of cures.
Yeah. And yeah, and I was going to say that in this particular training today, we're not focusing on tools and techniques for overcoming resistance, but we think those things are incredibly important. And we do a lot of teaching and training in the fast track program, in our free trainings, where we really focus on outcome resistance and process resistance. But we will be focusing now more on methods.
Yeah, and if you want, Jill and I might offer another one of these free webinars on the resistant patient, and then because we have a ton of new innovative techniques for dealing with resistance, and most therapists are not familiar with them.
And one other thing we'll highlight here, and then we'll also give you some clinical examples of throughout the webinar today, is this concept of safety behaviors. And so I'll mention it now because it relates to something you saw in the Terri video, and then we'll talk some more about it with some other clinical examples. But a safety behavior is essentially anything your patient does in the moment when they're anxious to reduce anxiety. And we use that very general term because very often patients will come into therapy thinking that they have all these great coping strategies, right? When I feel anxious, I make sure I have my medication with me. I say a prayer or a mantra. I, wiggle my fingers.
Let's see the next slide, Jill.
Okay, I'll do that in a minute. But essentially, the thing about safety behaviors is that in the short term, they make patients feel better, right? In the short term, they give you a sense of relief and even a kind of illusion of control over your anxiety. But in the long term, safety behaviors actually make anxiety worse because they don't allow you to learn that nothing terrible actually would happen, that you don't need the safety behavior in order to feel better. So they prevent new learning. And as you saw in the example, new learning is what happened for Terri, right? She needed to experience an intense amount of anxiety and to do those jumping jacks to learn that she was, in fact, safe. So on this slide, I have some examples of safety behaviors. And so for some people, it could be, carrying a lucky charm that makes them feel less anxious. For a patient that I actually just evaluated this past week, he told me that even though he didn't take benzodiazepines, he carried his container of benzodiazepines around with him, and he didn't see that as harmful. But see, in my mind, I'm seeing that he's telling himself, I'm not okay. And I know that I have this like escape valve just in case. And so he's not actually learning that he is safe, that nothing terrible would happen. For some people, a meditation or a mantra or a ritual, again, nothing wrong with waking up in the morning and doing some deep breathing or meditation as a sort of strategy for feeling good. But if it's something you feel like you need to do in the moment in order to not feel anxious, it's counterproductive. We have a couple other examples. I don't think I need to go through all of them, but patients with OCD quite oftentimes will be seeking reassurance from others, and they'll repeatedly ask for reassurance. It makes them feel better in the short term, but of course maintains their anxiety in the long term. Patients who have a fear of illness or a contamination anxiety will oftentimes carry hand sanitizers. They'll wash their hands repeatedly. So we just want you to get the sense and realize in your mind that there are a lot of things patients will do during exposure that's actually really counterproductive, and we need to be aware of them and we need to address those things. And so just to make it a little more interactive, we'll invite you, you can share just a few with us in the chat box and I will read a few of them. So any safety behaviors that you've seen in your patients that I didn't mention already, or that you yourself sort of rely on to kind of white knuckle or get through things when you feel anxious. So I saw someone say leaving the room, right? Right. In social anxiety, oftentimes leaving the room, avoiding eye contact. Someone said carrying a water bottle. Exactly. So someone else might be like, what's wrong with carrying a water bottle? Well, intrinsically, there's nothing wrong with carrying a water bottle. But if one thinks, I've got to carry this water bottle in case my mouth is dry, then it becomes a safety behavior and counterproductive. Carrying around a doll from childhood, eating sweets, looking at their phone, right? So distracting oneself. Yeah, and people are asking, is breathing or things like that, are those problems? Yes, if during an exposure exercise, someone is doing something to try to calm down, ask yourself, is that productive? No, because the point of exposure is being kind of all in, bring it on. I want to feel as anxious as I possibly can when I'm doing exposure. So if I'm doing grounding exercises or breathing exercises, I'm actually interfering with the effectiveness of exposure. There are ways, I will say, I've actually been contacted by therapists who say, can you integrate safety behaviors into a hierarchy? And we'll get into that in a few slides. But the answer is yes, you can, as long as you're aware of the fact that these are things that need to be dropped out and changed over time, and that they can get in the way of new learning occurring. So you guys added tons of great examples in the chat box, but I'm not going to read all of them. We'll move on and we'll give you some more examples of them a little bit later on. I'll just kind of cover this slide, David, and I can turn it back to you for the next example. But there's at least 4 types of exposures. There's in vivo exposures, which is when we're going to have our patients face the thing they're most afraid of in reality, right? So if a patient is afraid of a dog, they're going to hang out with dogs. If we're afraid of heights, we're going to go to high places. There's cognitive exposure, which is where you're helping the patient to confront the thing they're most afraid of in their mind. And we're going to walk you through an example and kind of teach you how to do cognitive exposure. That's especially helpful for exposure to things that you can't actually face in reality. Fears of things that might happen in the future, for example. There's interpersonal exposure, which we're going to do our next webinar, I think, on, or one in the future on, which is kind of a social anxiety exposure, smile and hello, shame attacking exercises. So a variety of exercises to confront social anxiety and interact with people socially. And then virtual reality exposure, which is where you can use virtual reality equipment, sort of similar to mimicking an in vivo exposure. It can help use all the senses to actually make exposure more realistic and helpful for things that, again, you can't easily confront sort of in real life. And then, David, if you want, you can talk about kind of gradual versus flooding here.
Okay, well, I mean, all exposure techniques pretty much can be done gradually or in a flooding way. And as Jill has mentioned, for gradual exposure, you can create a feared hierarchy and have the patient start with the easiest thing. And once they're used to that, go up to the next highest, next most intensely feared thing on their hierarchy, and then do that over and over again. Like for example, if you're afraid of heights, you could just go, the first few times, just go up the first rung of the ladder. And then the second time, once you're not afraid of that, you go to the second rung on the ladder, and you continue this gradually until you can stand on the top of the ladder. Flooding would be hitting your worst fear all at once, and that's what I did with Terri. And also, when I had a fear of heights in high school, I want to be on the play, the stage crew of the play Brigadoon, and the drama instructor, teacher said you have to do work at heights to be at on the stage crew. And I said, well, I have a fear of heights. And so he said, if you'd like to get over it, we can do it right now. And so he took me into the theater, and there's a big V ladder there. And he said, just stand on the top of that ladder and then I'll wait here at the bottom of the ladder until your anxiety disappears. And that was flooding. And I stood up there for 10, 12, 13 minutes, and my anxiety was 100 out of 100. I was just standing on the top of the thing, and I kept saying, Mr. Kershak, I'm still 100 on anxiety. He said, well, just it'll go down pretty soon. Just keep standing there. And then suddenly, after about 14 or 15 minutes, the anxiety dropped to zero, and I was no longer afraid of heights. And then I loved being on the stage crew, and I would work up at the ceiling and working on the lights and the curtains and all of that. And I couldn't even remember why I'd been afraid of heights. But both techniques are effective, and it's kind of personal choice.
Yeah, I was just going to say one other thing, David, while we're talking about exposure, is that when I learned, and I'll share a little bit about this later, but when I first learned to do exposure, which was actually kind of one of the first methods that I learned in graduate school, I thought of it in a way as like a way of life for myself, which is, I didn't think I could ask my patients to do something that I wasn't willing to do myself. And so I kind of set out to identify, were there any things that I was fearing and avoiding, and could I go ahead and face those using the same techniques that I was encouraging my patients to face. And David, I think that's, you and I both have a lot of confidence in exposure therapy. And I think that's also because we walk the walk, right? When we do
Yeah.
see that there are things that we fear and avoid, we go ahead and we're kind of all in and we face them.
Yeah, I've had over 17 anxiety disorders since I was little, so I know very well what all the kinds of anxiety are like, and I know very well how to get rid of them and get cured from them.
So we'll talk a little bit about gradual exposure now, and we'll cover flooding in a little bit. But with gradual exposure, the goal then is that we're going to kind of break down the fear into a hierarchy, or like a list of examples of situations where the patient might fear and avoid this thing. And this can be done with any type of fear. So if one is afraid of dogs, we're trying to make sort of a hierarchy of least anxiety producing to most anxiety producing situations, right? It could be little to big dogs, but it could even be watching a movie about a dog. And so I'll share with you guys a fear and avoidance hierarchy that I developed for a patient that I treated for a fear of driving. I've actually treated a lot of patients in my career who have a fear of driving, and I will say I kind of have a soft spot for it because the very first patient I ever treated in graduate school had a fear of driving, and I'll give her example. I was a grad student at Boston University, and my office was right near Fenway Park, right in the middle of Kenmore Square. Very busy, lots of driving going on. And this first patient that I ever treated, her name was Patty, and she had this intense fear of driving. And interestingly, a lot of people think people with a fear of driving, it's because they're afraid of having an accident. Maybe they had a traumatic experience, but actually many patients I treat, it's just that they had a panic attack while driving, and that scared them tremendously. And the fear is that I'll lose control, that I'll crash the car, that I'll pass out while I'm driving. And so just to stick with the fear and avoidance hierarchy, we kind of created a hierarchy together from least anxiety producing to most anxiety producing. So something that felt kind of easy but still a little scary to her was just simply driving to the end of her street, because she had completely stopped and avoided driving, even though she used to drive all the time. And the next step would be driving to her kids' school, which was a couple blocks away, driving to the grocery store. So the point is that you're kind of creating this hierarchy. You can even add things like during the day or at night in a crowded time or at a busy time. And the goal is that you're just creating this list from sort of least distressing to most distressing. And in her case, driving over bridges and in tunnels in Boston was the most anxiety producing thing that she could imagine. And then we essentially use exposure. And I can say with this patient, of course, like with all of our patients, I'm integrating other models. I always start with testing and empathy, and also a lot of cognitive therapy to understand what was she most afraid of, right? In her case, she was most afraid of passing out, losing control, getting into an accident because of her intense anxiety. And so then what we did was we practiced together each thing on the hierarchy, and I would do it with her in session, and then I would assign it to her for homework. So she could do it with me, but then she needed to repeat it daily for homework. And we would move on to the next step on the hierarchy when her anxiety rating would drop. So the goal is that you kind of stick with each activity till the anxiety goes down. There's no magic number, but I always say till it's maybe around a 20 or something like that. I also want to just point out, and I can say that with Patty, it was incredibly effective, actually. And I did, do the driving with her, and she was also willing to do the driving on her own for homework. I was super aware with Patty, as I am with all my patients, of what she was doing when we did exposure, that might have actually been sabotaging her success. And so she wanted to distract herself. And that was the strategy she had been using to sort of white knuckle it and get through the driving on her own. She would turn on the radio and try to just pay attention to the radio so she wasn't paying attention to her sensations. She would open the window because she was hot and sweaty and she thought, oh, that'll make me sort of feel better. I'll be able to breathe better. She would carry medication even though she wouldn't take it. Say mantras to herself like, you're okay, you're okay, you're okay. And sometimes even use the phone to talk to a support person. I also want to point out something that I think is really interesting. My experience with driving phobic patients is sometimes their safety behaviors make them feel better in the short term, but actually were interfering in their driving, which is kind of fascinating. It was making her a more dangerous driver that she was doing some of these things because she was distracted from the road. And that's how you know it's a true safety behavior, right? It's actually causing more harm than good. So we integrated those in the hierarchy. It was important that she dropped out these safety behaviors, both for her actual safety, but also so that she could realize that I can drive and feel anxious and still drive safely. The other thing that I integrated in my work with her is what we call hypothesis testing. And I know, David, you love this technique, and so I'm happy to let you describe it. Did you want to do
Well,
that?
it's just something I recalled from when I was going to Beck's weekly seminars when I was first learning cognitive therapy, and he just mentioned a patient who had a driving phobia and had the thought, I'll lose control of the car. And so he had her do experiments while driving, not to distract herself, but to test that hypothesis, the same as what I did with Terri. Like, can you turn the radio on and off, or change the station, the radio station? Can you speed up by 5 miles an hour? Can you change lanes? And then, when she reported back, could you do all of these things if you had lost control? And so it's just a way of integrating a cognitive dimension into the exposure.
And even, yeah, with the Terry video, she said, I'm afraid I'm going to pass out. It's like, well, what can we do to test that, right? And so if you have a patient who's saying, I'm afraid I'm gonna lose control, we're saying, what's an experiment we could do to test that? Can you do A, B, and C? And I do find that to be very effective with, particularly driving phobia, but in general with doing exposure, is making sure that you're kind of testing that hypothesis. And I'll do this slide as well. So tips for successful exposure. Well, longer sessions can be helpful because if we want to do an exposure with a patient and make sure that they stay in the situation until their anxiety comes down, then having more time to do that can be really helpful.
Yeah, I often schedule double sessions when I'm doing exposure. That's what I did with Terri. She was one of the first people I scheduled a double session for, and it worked like a charm.
And more frequent sessions can be helpful, particularly if you have patients who's kind of have a lot of anticipatory anxiety. They're worried about doing exposure. The more we do it, then the more we can kind of like get the hard work out of the way, the better off they're going to be. So treating them for longer sessions and more frequent sessions just during this kind of exposure phase can be helpful. Having them do daily homework. So basically repetition can be really helpful for patients. And I do always ask patients to practice what they're doing in session, out of session, not limiting your treatment to the office setting if you can. And I know a lot of people are doing video therapy with patients that maybe don't even live close to them. And so you have to do the best that you can. But if you have the ability to meet your patient outside of the office session and do exposure with them, that can be extremely helpful. As we've already talked about, persisting when inevitably in the moment the patient will want to back out. And really, that's just encouraging them. It's showing them you believe that they can do this hard thing and get better. And sometimes modeling the behavior for the patient. So in the case of David and Terri, if that were my patient, I might have even done jumping jacks with the patient. If a patient is afraid of spiders, we might hold spiders together. So there's something that can be helpful about therapists being willing to face, the fear along with the patient. I did see some questions coming in about safety behaviors, and maybe we can answer those at the end of the presentation, since I know we have a lot of other things that we want to cover. So I talked about kind of the fear and avoidance hierarchy and moving through things kind of methodically and slowly. And then David's going to share with you a story about someone we worked with together in the Tuesday group where we did flooding rather than kind of gradual exposure.
Yeah, this was a beautiful woman, and a wonderful woman in our Tuesday training group, and she used to bug me that she wanted me to treat her contamination phobia, her OCD. So one Tuesday we decided to do it in the group. And I'm going to skip the empathy part, but it was critically important. I'm going to skip the assessment of resistance, getting her over her outcome resistance and her process resistance. But her story was she had the same thing that Howard Hughes had, like intense fear of germs and elaborate rituals in the shower, washing her hands and cleaning herself for an hour or 2 hours. She was especially afraid of touching doorknobs, and whenever she went into a building, she would have a tissue paper that she would use to open the door and this type of thing. And she'd been struggling with it for a good 20 to 25 years. And she knew, that I was going to, be making some strong demands on her in the methods section. And so once we came to the methods, I said, okay, now we're going to, confront the monster you fear the most. So we left the seminar room. There were about, I don't know, 25 or 30 students there in the seminar. And we went into the women's bathroom in the behavioral sciences building. And fortunately, there was no one else in there. And so all 30 people went crowding in there. And we, went over to one of the toilets. I said, I want you to touch this toilet seat with your hands. And she said, oh, no, I couldn't possibly do that. And I said, oh, you can. You just move your hands and you start touching the toilet seat and rub your hands all over the toilet seat. And she said, I'd like to see you do it. So I said, okay. So I started rubbing my hands all over the toilet seat. And then she saw that nothing happened to me. So she did the same thing. And then she picked up the toilet seat and rubbed her hands around the inside of the toilet, which I thought was very brave. And I asked her how anxious she was, because she had estimated it initially at 100 on a 0 to 100. And she said it had gone up to 120. And I said, okay, we're moving in the right direction. And one of the ideas is you don't try to help the patient relax or feel better during exposure. So you do the opposite. Say, you got it up to 120 out of 100 is good, but now let's see if we can get it up to 150. Let's walk out to the front of the building, and there'll be a lot of door handles along the way. And I'm going to have you touch every door handle without tissue paper. And so this was really, really freaking her out. But she was a good egg, and she was doing it, and all these 30 students were traipsing after us, and it was kind of fun for them to see something live and happening in real time. And then we got out in front of the building, and there was an empty garbage can there, right outside next to the entrance to the behavioral sciences building. And I said, now I want you to to put your hands in here and rub your hands around in that, grimy black stuff. And it was really disgusting. And she said, oh, no, I couldn't possibly do that. And I said, oh, yes, you possibly could do that. And you are going to do that. Again, I'm pushing her. I'm insisting that she does this. And that's one of the important keys, to do that with compassion. Again, I had gotten a perfect score from her on my empathy. So she really admired me and trusted me. So she said, no, if I put my hands in there, I'm going to vomit. And I said, that would be even better. Just put your hands in there and then vomit all over everything and rub your hands around in all that grime, because it was like a millimeter of black grime all inside that garbage container. And she said, well, I'd like to see you do it. So I put my hands in and rubbed them around, and they got all black. And then I rubbed it all over my face. And then I said, okay, Sarah, now I want you to do that. And I'll show you what happened in the next screen. This one of my students had an iPhone there, and there's Sarah next to the garbage can, and you see her sticking her hands in right now. This is an ultra short video.
Right, it's a super, super short video, so you get to hear the story and you just get to watch the last few seconds here. So I will press play right now. Oops, hold on.
Oh, beautiful.
Yay!
And then we went all back into the seminar room and sat down, and I saw that she was crying. And I said, Sarah, what are you crying about? And she said, Dr. Burns, I'm cured of my OCD. And I'm just unbelievably grateful. I'm not afraid of germs or contamination anymore. And that was just an awesome experience. Then again, by way of follow-up, because some people say, oh, well, anyone can do that, but does it last? And she's now been free of, OCD and germ phobia for, it was at least 2, 3, 4, 5 years ago. And she unfortunately has a flu, or she would have joined us today to be happy to talk to you or answer any questions that you had. But she's just a delightful person. But again, it was the curative thing. And just like Terri, it took courage on my part. It took courage on her part. She kept trying to tell me this is too dangerous, but you have to push ahead. But you get pushy in a kindly and loving way, and that's part of the art of therapy, is to know, how to balance those two forces.
And I was going to say, David, some people have questions, and we will not be addressing these kinds of questions about like isn't that dangerous, or like isn't driving inherently dangerous, aren't germs inherently dangerous. What I will say, if you want to make a quick comment, David, you can, but what I will say is, of course, life is inherently dangerous. And so, we're not ever promising our patients that they're protected from danger. This is part of what we call agenda setting or assessment of resistance. We're making the decision with the patient that it's worth it to them to tolerate some level of risk to gain freedom in their life, right? We're doing cost benefit analysis. We're looking at how much it's costing them to do the things that they're doing. And we're making that choice ahead of time. So we're not taking patients and saying, you must do this to get better. We're having a whole conversation with them about what change looks like, what they really want, is it worth it to them to do the work it's going to take to get there? And we decide all of that ahead of time. But then when we're in the moment and we're actually doing exposure that we've decided upon with the patient and resistance shows up, that's when we are, confidently forging ahead, because we know we've made the decision that this is the right thing to do, and that the only way the patient is going to get over it in this moment is by going through it.
Yeah, but I think those questions just show how all you folks are being hypnotized by our patients too, thinking, oh my goodness, it's dangerous to touch a garbage can.
Right.
Yeah, I know a lot of therapists used to say, wasn't it dangerous? You asked Terri to stand up when she said, if I stand up, I'm going to pass out. And you asked her to stand up. Wasn't that terribly dangerous? Well, let me ask you folks, is it dangerous to stand up from a chair? Have any of you ever sat in a chair and then stood up? And is that a terribly dangerous thing to do? You see, the patients are putting us in this hypnotic state. I'll check it out right now. I'll see if I can stand up. Yes, surprisingly, I could stand up.
And then, of course, people will have questions like, what if someone has a heart condition? Well, all of those things are very specific. Of course, we're never intentionally putting our patients in danger. And I will say, for patients who have panic attacks that come to see me, they've usually the people who've had the full cardiac workup, they've been to the ER many times, like you have evidence that they do not have a heart condition. They've already ruled that out. We know that it's anxiety. But I think we should forge ahead because we've got more
Yes,
to share, and
sure, yeah.
we can always answer more questions at the end if
Yeah,
we have more
yeah,
questions.
but thank you for all these questions. And
Yeah.
means you're engaged and you're touching on the most important things and issues emotionally for therapists and for patients. Like, what is the price of a cure?
Yeah.
You know. Okay, in the what if technique is a great it's cognitive technique, but it's a cognitive exposure technique, you might say, and you want to uncover a patient's core fear using the what if technique. And then once you uncover the core fear, you have them confront that using exposure. And to give you an example of that, a man was once referred to me by a colleague in Philadelphia, who said he thought this guy was the top courtroom attorney in the United States, that he had lost only one case in his entire career, but he was very unhappy. And he was a very nice fellow. I just liked him tremendously. But he had only lost one case in court during his entire career, and he was in his 60s. And that's so very unusual because every time an attorney wins, the other attorney loses. And so for him to have a record like that was pretty unbelievable. And he took on giant corporations in environmental contamination cases, and he brought them to his knees. He worked, solo on these incredibly difficult cases, and virtually nearly always won. But he told me that he'd been unhappy since he was a little boy, and he hadn't had 1 minute of happiness in his whole life. And when he came to me, he had just completed 30 years of 5-day-a-week psychoanalysis. And I asked him, what did you find out? Did you find out why you've been so unhappy? And he said, well, the psychoanalyst told me it was because I had a baby brother who died when I was little, died in a fire, and I'm subconsciously blaming myself for his death. And I said, was that true? And was that helpful? He says, I have no idea if it was true. I can tell you it never helped me. Nothing helped me. And so the thought that on his daily mood log that kept coming up was, what if I lose a case in court? And he told me that he would just work 7 days a week preparing for cases, and that he couldn't even go on vacation anymore because he just worked constantly on vacation. So I wanted to see what was his worst fear. And so I did the what if technique. And this is an easy technique to do, which you might enjoy incorporating it in your practice if you haven't already. It's one of 3 powerful uncovering techniques. And if we go to the next slide, I'll show you how it works. So he was saying, what if I lose a case in courts? I say, write that down on a daily mood log in the negative thought column and put an arrow under it. And the arrow means, this is the downward arrow. If that were true, what would it mean to you? Why would it be upsetting to you? And whatever the patient says next, you say, good, write that down. And then you keep doing it until you get to the core belief. And so he said, well, then people will lose confidence in me. And then he wrote it down, and I wrote it down, and I said, let's suppose that happened. What would happen next? People lose confidence in you. What are you the most afraid of? And then people will stop referring clients to me. And then what's the worst that could happen if they stop referring clients to you? What are you the most afraid of? Well, then I'll go bankrupt. And which was kind of absurd because the guy was pretty darn wealthy because he was such a successful attorney. But if you went bankrupt, then what then? What are you afraid of? Then my wife will leave me, and my daughters will stop loving me. And then what's the worst that could possibly happen? And he said, then I'll end up homeless and alone. And his core fantasy was being a homeless man on the, on the streets of Philadelphia and begging for with a tin cup, and then attorneys he beat in court walk past and kick sand in at him and say, "Oh, there's the great Jeffrey. He used to think he was so fantastic, and look at him now. He's pathetic." And although he rationally knew this wasn't going to happen, emotionally he believed this would happen, that he was in danger. And so this downward arrow not only showed me his core belief, but his self-defeating beliefs, which was perfectionism. He believes I must be perfect, but especially perceived perfectionism. People won't accept, respect, or love me if I fail. And I was trying to find how can I get him to crush these core beliefs, and the answer is, find a way for the patient to confront his worst fear using some form of exposure. And so when he was working with me, he coincidentally lost his second case in court. And it was just a trivial case he took on pro bono as a favor to a friend. And the reason he lost is the man he was defending was as guilty as sin and, deserved to, to lose the case. But he was terrified that people would find out. And he was thinking, how am I going to hide this so people don't find out? And so then the experiment came to me, and he was the chairman or the law board, or whatever it's called. He was the head of it in Pennsylvania, and they were having a meeting that week. And I said, at the meeting, tell 10 of your colleagues that you just lost a case in court, and then find out how they respond to you. And you can keep a 3x5 card in your suit pocket. He used to wear these very expensive suits and bow at the beginning of sessions, very formal, like some powerful attorney. And then if they respond negatively, you put it in the negative column. If they respond positively, you put it in the positive column. And if you're not sure, you put it in the third column. And he resisted this intensely, that he didn't want them to find out he'd lost a case in court. But again, I had to say, you must do this if you wish to continue working with me. This is not a negotiation. This is a demand. And he was a good egg. He'd suffered his entire life. He said he had never had 1 minute of happiness, and he'd do anything to if he could overcome this. Oh, I see. Okay, yes, we'll come back then to it. And the next week he came in, and he said that he was stunned by what happened. And he pulled out his 3x5 card, and he told 10 attorneys, I just lost a case in court. And he said 5 of the 10 appeared not to have heard what I said. And they just kept talking about how great they were and all of the cases they'd won, and, kind of bragging the way he said attorneys tend to do. And I realized I'd been involved in the distortion of magnification and minimization, magnifying my importance in the eyes of other people and minimizing the extreme narcissism of American attorneys. So he said that was a relief to, that reaction that they had. But he said the other 5 was even more powerful. He said not only were they not critical of me, they opened up right away. And they said, oh, Jeffrey, God bless you for telling me this. It's a relief to know that someone as great as you, one of maybe the greatest attorneys in American history, can lose a case in court. And I feel so much closer to you now. And let me tell you about all the cases I've been losing in court. And let me tell you about my wife who's about to divorce me. And let me tell you about my children who were using drugs and hanging out with the wrong crowd, and I don't know how to talk to them. And he said, Dr. Burns, and tears came to his eyes. He said it was the weirdest thing in the world. I felt joy for the first time in my life. I felt that I had something to give people. And my anxiety, my fear disappeared finally after 60 years. And it was such a heartwarming thing because, and his whole persona changed and he stopped acting so formal. And because I actually didn't like him because he was so formal and I was afraid, and, he was so formal. I thought maybe he's getting ready to sue me or something like that. And then when he showed his vulnerability and reported that back, he became like a regular fellow, of like a friend. And I felt so close to him and felt so much warmth and admiration and gratitude. And I think that's one of the beautiful things about our work is we're not just treating symptoms, but we're trying to save the life of a human being and cause a meaningful transformation in someone, to try to bring someone actually like Jeffrey to a state of enlightenment. And sometimes recovery has a kind of a philosophical or almost spiritual dimension, and it was certainly the case for Jeffrey.
It's also a beautiful example of how therapy is such an art form, that we can teach you all the different components and different strategies and methods. And it's also somehow, there are just times where you decided to do the what if technique to uncover what that core fear was, and probably didn't know ahead of time what you'd end up finding. And once you found it, you had to be sort of creative, like how can we actually figure out if this is true or not, right? You did some interpersonal exposure
Yeah.
with him. Again, that kind of the self-disclosure and a survey technique, and sort of each method built on the other to end up with such a kind of beautiful outcome.
Yeah.
And so, we are going to talk to you a little bit about kind of two forms of cognitive exposure that can be really helpful when you're working with patients. And one of them is cognitive flooding, and I'll talk to you guys a bit about cognitive flooding. And the other one is memory rescripting, and David will share with you a story where he used memory rescripting. And some of you have asked in the chat, what do we do when we have things that patients are afraid of that they can't really confront in reality? Someone texted, that they have a patient who's really afraid of getting a terrible illness. And so these are the examples where cognitive exposure can be incredibly effective. So cognitive flooding in particular is where we'd have the patient actually close their eyes and imagine kind of the worst thing, the thing they're most afraid of happening. And in fact, the what if technique that David just shared with you can be really useful in getting to that core fear. What is it the patient is most afraid of? And then once you get there, you can have the patient close their eyes and imagine that terrible thing happening. So if it were that they were afraid they'd get sick and even be suffering and eventually die of a particular illness, they could actually imagine that. We'll do it with the patient in session, and we'll actually ask the patient throughout the cognitive exposure, the telling, what their anxiety rating is from 0 to 100 every minute or two. That's really so we can understand what are the hardest parts of the exposure for them. And also so we know if they're not really doing it, meaning if they're not very anxious, we want to try to encourage them to think about it in a way that's going to bring on more anxiety. Can you get yourself to be more anxious or worried about it? So you can tell if the patient's avoiding because you're asking them for their anxiety rating. We're encouraging them to constantly try to intensify the anxiety, and we're going to have them continue doing it until the anxiety goes away. We also record the exposure with them in session. So nowadays that's pretty easy because most patients have a recording device on their phone. And then we can actually assign it to them to listen to that recording over and over again for homework. And I'm going to walk you through an example of this. I actually do like to have my patients write out a script. So some people will just have them close their eyes and imagine it on the spot. I just think sometimes it can be helpful to have people write out the script. And so they're asking themselves, and what happens next? And what am I most afraid of? And they can kind of write it out. Then they can actually read the script in session. And also just to address some therapist questions, sometimes an exposure might be 10 minutes long. And I usually try to get my patients or assign my patients to do their exposure for 30 minutes a day, every day. So if it's a short script, I say then you just keep listening to it over and over again until the 30 minutes are up. If it's a 15-minute script, you can listen to it twice. But the goal is to really get them to kind of lean in and bring on all of what they're afraid of. And I'll give you an example. There was a patient that I was working with many years ago who actually had contamination OCD. So she was worried and about contracting an illness, and she was worried that it was going to get her sick and get her children sick. And she had very kind of classic contamination OCD. But what kept coming up in sessions was she was also so worried about the idea that her OCD was going to lead her to lose her mind. And so while we were doing different exercises using hierarchies and things like that, and exposure and response prevention to work on her OCD, what kept getting in the way of therapy actually was her ruminating and obsessing about the fact that this OCD would never go away and that she would ultimately lose her mind. And so I thought, maybe we need to address this kind of category of anxiety before continuing on with this contamination exposure. And so I did the what if technique with her to understand, what is it that she was most afraid of? You might be thinking, well, losing her mind is bad enough, isn't it? Like, isn't that what she could imagine? But I was curious and I asked her, like, let's imagine that you did lose your mind. What would that look like? And then what are you most afraid of? And it turned out that she was actually most afraid. She had 2 young children. She was most afraid that she would end up being hospitalized and in sort of institutionalized, and that her children would grow up without a mother. And when she got to that sort of admission, she was sobbing. And that was truly the thing that she felt most afraid of, that she would abandon her children and that they would be left kind of not alone, but without a mother for the rest of their lives. And so we decided to address that using cognitive exposure. So I had her write this script and then record it with me. And I will tell you that doing cognitive exposure with patients can be extremely painful. You'll have patients who are imagining the most terrible things happening to them and sobbing, in your office. And that's what happened with her. And again, just like David, I had to be confident and kind of pushy and saying, I know this feels awful now, but this is what we need to do to kind of get you to the other side. So I had her recorded, and her anxiety was up at 100, and she was crying and skeptical that this would actually be effective. But we did it in session, and then I assigned it to her for homework and asked her to listen to that recording, 30 minutes a day, every day. And I said, it doesn't matter how long it takes. We're just going to keep doing it until this recording no longer bothers you, which sounded kind of incomprehensible to her. But a week later, she came back having listened to her recording every day. She was happy to report that honestly, it bored her. She just didn't really think about it very much anymore. She kind of got used to listening to herself, and the story seemed ridiculous and unlikely, and it just didn't bother her anymore. And we needed to then kind of shift gears and get back to working on her contamination OCD. But she no longer brought up this fear that she was going to lose her mind and end up abandoning her children. So it was incredibly effective. But also, I relate to that therapist experience of worrying in the moment. Am I actually making my patient feel worse, right? But it's this idea that more anxiety in the short term is going to bring relief in the long term. And David, did you want to share your story about memory rescripting? We do have time for you to do that, and then we can shift gears and do some questions and some follow-up information.
Well, I'll see if I can give a kind of quick story of it. But essentially, with memory rescripting, you have the patient close their eyes and go into the past and relive some horrible traumatic experience. But you can also have them change the script, have it come out a little bit differently. So that they're in control, and it's just a concept, and you can do it in 100 different ways. But I was doing an intensive for a small group of maybe 35 therapists in Southern California a number of years ago, and that's a 4-day training experience. And we work, from morning till late at night and have dinners together, and it's very, very intense. And people's defenses break down and they open up and we start feeling close to each other, by the second or definitely third day of the intensive while learning techniques. But there was one fellow that didn't fit in very well. He said that he was a pastoral counselor from New Mexico, but he was very formal and like kind of always trying to impress people. And I remember my father was a minister, and when he prayed, he used to pray with a warbling voice, like, "Dear Lord, please bless us, thy people," like that. And I shouldn't probably be critical because he had a congregation who really loved him. But I used to think, "Dad, why do you have such a stupid warbly voice when you pray? Does it go through the clouds better and get up to God if you're warbling? And why do you speak in medieval English? Doesn't God understand modern English?" And it was irritating. And this guy was like that, talking this warbly voice all the time. And he wasn't, connecting with people. And I was doing a segment on, what we're doing now, like cognitive flooding. And I was talking about how a picture in your mind, and you focus on it, it'll often bring powerful emotions. The pictures are almost like sentences that upset you, upsetting pictures. And I was about to go on to the next technique, and this fellow, this pastoral counselor, raised his hand and said, "Could I ask you a question?" I said, "Yeah, sure, no problem." And he said, "Are you saying that a picture in your mind can create a lot of powerful emotions?" I said, "Yeah, yes, Pastor, that's right." And he says, "Well, I have a picture in my mind right now." And I could see he was getting real shaky, like he was about to start sobbing or something like that. And I said, what's the picture of?" He says, my nephew Jimmy. And he said, you see, I said, "Tell me about your nephew Jimmy." And I said, "Well, you see, I've been telling you I'm a pastoral counselor from New Mexico, but that's not my true identity. I'm actually someone different from that." And I said, I got shocked. I said, "Well, what are you doing at the workshop? And who are you in reality?" He says, "Well, my name is Johnson, and I am working as a pastoral counselor, but I'm actually a pilot." I said, "Oh, what airline do you fly with?" And he says, "No, I haven't flown a plane for, 25 years or 30 years or something like that." And I said, "Well, tell us about that." And he said, "Well, I was a pilot in Vietnam, and I became the head of the thing. And so I was supervising the bombing missions over North Vietnam and Cambodia." And he said, "My nephew Jimmy was one of my pilots, and that's my wife's only child, or my sister's only child, my nephew. And she wrote to me a letter that said, 'We pray to God every night. Please don't let anything happen to our Jimmy.'" And he said that night Jimmy came back in a body bag. And I went down to, identify the body, make sure it was Jimmy, and they opened up the body bag, and I looked in, and his face had been blown off. But I knew that it was Jimmy, and I thought I would start sobbing, and something happened in my brain, and my emotions got turned off. And I have had no emotions for 30 years. I can't feel anything, Dr. Burns. That's partially why I came to this conference, because I'm a human being, but I don't have emotions. And I don't know why. I can't feel anything. And he was just shaking, and I said, "You look to me like you're on the verge of tears right now. Maybe you need to go ahead and let those feelings out right now." And then he just started sobbing uncontrollably and just shaking, and snot was going down, out of his nose, and tears were flowing down his cheeks. And he put his head in his hands, and he was just shaking, and half the workshop started sobbing. And then he pulled himself back together, and a woman sitting opposite him said, "Pastor Johnson, I want you to know that during the Vietnam War, I was one of the protesters here in Los Angeles, and we hated people like you, and we protested against people like you. But I can see that you gave your best for the country, And I just wanted to say thank you. And then she started sobbing and he started sobbing again. And then afterwards, he said, you've all heard about the Medal of Honor. The U.S. gives out the Medal of Honor. Well, so did the Vietnam government. And I received the Medal of Honor for the things I did, in Vietnam from the Vietnamese government. And when we came back to America and we got off the plane, uh, there was no one there in the airport waiting for us. My sister wasn't there, our friends weren't there, our family weren't there, none of us, nobody was there to greet us. And when we walked through the airport, people started spitting on us. And Jan, the thank you you just gave me is the first one I've received in the last 35 years. The only thank you I've ever gotten, and then everyone just burst out sobbing at that point. And that was it. But we didn't need to do the rescripting. All he needed to do was to visualize the face of his nephew, and that brought all the emotions out. And that night when we went out for dinner, we got pizza someplace as a group, and he sat next to me, and all that warbly voice thing had disappeared, and he was just so cool and awesome and funny and friendly and down to earth. Uh, but that's how you can bring people into the past, and then work with the memories and images in a just a huge variety of ways. But that is just to give you a feel for the power of pictures as well as thoughts. Pictures are cognitions just as thoughts are cognitions, and they can contain potential emotion. And as a therapist, you don't want to be afraid of emotion, but go with the patient to the gates of hell, because that's often where the miracles occur.
Absolutely. Such a beautiful story, David. And you're such a talented storyteller, too. I think we could
Thank you.
all sit and listen to you for hours. So I think what we will kind of cover just some brief take-home messages, and then we'll share with you some follow-up training opportunities, and then we'll go to the Q&A until the end of the hour. I'm happy to talk about this, David, and unless you want to.
No, you go ahead. Yeah.
Okay. Yeah, I think we've highlighted these points throughout, so maybe this is all pretty clear to you guys, but clearly we're asking our patients to do really hard things, and so trust and rapport are super important, as is hope and confidence on the part of the therapist, instilling hope in our patients that they actually can get a cure, that they can get relief and get over this thing they've been afraid of for so long, and our confidence and belief that we have the tools to be able to help them. And I would say if you're a therapist who's like, but I don't have that confidence, well, then get more training, right? Seek out training, consultation. Just occurred to me, I didn't even put a slide about this, but I run an exposure consultation group where we just talk about how to implement exposure. We have lots of other consultation groups and trainings on the topics in general, but get support, get consultation, get supervision. Don't forget that it's super important to initially address outcome and process resistance, and come to another training where we teach you how to do that, but recognize that we're not just jumping in and doing exposure with our patients. Exposure is one of many ways of treating anxiety, and in any case, you definitely need to be addressing resistance and motivation. Remember that you can use gradual exposure or you can use flooding. Make sure that you pay attention to safety behaviors, because they can really sabotage exposure and overall treatment. And don't settle for partial recovery. Know that your patient can get over their fears and that you can help them to do that. And again, that exposure is a really powerful method that you can have in your toolbox to help that along the way. So I'll do a little bit of sort of like, if you'd like to learn more, and then we'll take your questions, and Mike has been collecting them throughout. So if today's training sparked something in you, and if you feel excited about what you learned and you'd like to take your skills deeper, we'd love to invite you to join our Fast Track to Level 3 certification course. It's our kind of most efficient and powerful way to help therapists that are interested in learning and growing and kind of mastering these strategies. What we covered today was literally one of 50 plus methods that we teach in the Fast Track course to help therapists become better therapists and to help patients to recover faster. I'll just share this kind of one testimonial that Sarah Chickering shared with us, which was that this course was one of the best decisions that she'd made for herself professionally because it really grew her confidence and her toolbox. And this slide is kind of packed, but just to give you the full picture of what's involved, our Fast Track course begins on September 11th, and it's a hybrid format. It's designed for busy professionals, so you get to watch videos of me and David teaching. I'm doing a lot of the didactic teaching, and David and I have a lot of interviews and, again, cool stories to share with you, and you kind of consume all of that asynchronously at your own pace. And then we meet weekly where you can actually practice the tools that you're learning. And so you have a weekly practice group. We also start out with a David Burns Live. So there's a 4-hour live kind of teaching session where we're actually working with a therapist who's functioning as a patient, and you get to see us kind of bring this model to life live. You also get a certification, you get the therapist toolkit, and right now there's a $50 off coupon for it that you can use if you sign up, I think, today. And Mike is sharing the link with you in the chat box. And beyond the Fast Track course, there's David's app, and I'm going to let David tell you a little bit about the Feeling Great app.
Yeah, the Feeling Great app is it's free for the summer between now and probably the end of September, and it's both classes and lessons. It's for you and your patients, but there's also we've trained the AI to function pretty much the same way I function in an actual therapy session. And we've gotten beautiful endorsements from people that it's been life changing. We've looked at the research data and the reduction in negative feelings, not only depression, but anxiety and anger and hopelessness and loneliness and inadequacy. All diminish with most patients within a couple of hours the first time they sit down with the app. So if you're an individual wanting help with depression or anxiety, here, jump on the thing right now. I don't know if we'll be around forever. But it's in existence now. The Feeling Great app, and it can be helpful. It can be an adjunct if you're in therapy with someone. But it can also help you if you don't have a therapist. It's not trying to be therapy. It's a self-help tool, much like my books, Feeling Good and Feeling Great and When Panic Attacks. But it's a new tool, and it's quite different from anything else. And it's just beautiful. The empathy that it does is mind-blowing. It'll melt away resistance, and it knows many of these techniques we've been talking about in today's seminar.
Yeah, and also the Feeling Great app is great for therapists as well. And you can get the app, and your patients can get the app, and then you can actually be giving patients homework and things like that to really enhance the therapy that you're doing with your patients. And then we also just put this slide up, and now we're going to do some Q&A, but there are other ways you can learn and grow with us. We have a free weekly practice group David and I run on Tuesday evenings from 5 to 7 p.m. And if you're interested in that, you would contact Ed Walton, that email address. That's it's not a drop-in group though. You need to make a commitment that you're going to come regularly if you'd like to be a part of it. That's only for therapists. There's also one on Wednesday mornings with Rhonda and Kai, similar kind of format for therapists
And I want to emphasize, if some of you want to learn more about what we've taught you today and really learn the fine points, that's unlimited free training every week from David and Jill. And so if you'd like to, and it's virtual, so you can join from anywhere in the world.
Yes, and then you can also get David's podcasts and the Feeling Great on YouTube. And so those are other options for additional free training. We're going to go to Q&A now, and then at 55, Mike will drop the link to the CE survey. So you have to complete the CE survey today when we drop it in the chat box, because you have to be present for the whole time. And then you'll get your CE certificate via email within 1 week. But now we'll move on to some Q&A.
At the beginning, you introduced the 4 different models. Is there a way to sort of surmise which model might potentially be best for the person? What model do you use for different people?
No, I don't think like that. I use all 4 models for every anxious patient that I treat. We've only shown you in detail the exposure model and a little bit about the cognitive model, but with every single patient, I empathize, and then I melt away resistance. Outcome resistance and process resistance, and also the hidden emotion model that we haven't talked about at all today is absolute blow away, and is so helpful for many anxious patients. I go in with all guns blazing with every patient.
It seems the trend for these techniques are using exposure for the perceived fears versus a lived traumatic experience. Am I assuming this too much? And that was towards Jill, that question.
Yeah, I would say no. The answer is that's not true. So my understanding of the question is saying, are we doing cognitive exposure only for, what we imagine to be the worst case scenario? And no, actually, I use cognitive exposure very often for patients who have post-traumatic stress disorder, right? So the thing that we actually use the cognitive exposure for is the trauma memories. And David gave an example of that. So that question might have come before David's example. But with post-traumatic stress disorder, it can be extremely helpful actually to have the person retell the trauma memory, right, from beginning to end. And some of the hardest work that I've done has been sitting with patients recounting truly, horrific childhood physical and sexual abuse, 9/11 stories. And yet that can be some of the most powerful work. So yes, this exposure can absolutely be done for lived experience as well.
Yeah. Yeah, I would say in my case, trauma patients have probably been the easiest group of patients to treat. I had one that took about 10 or 11 sessions, very severe sadistic childhood sexual abuse that went on for 5 years. But almost all my other trauma patients have been single session cures, you might say. But when I say a single session, I have always treat people in 2-hour sessions, and I treat people for free, so money isn't an issue as far as time. And I just work with someone until their symptoms have disappeared, and trauma patients have been just incredibly responsive to team and all these techniques, including the exposure techniques, but especially the cognitive techniques.
Question, David, regarding Terri. How do you know she wasn't just pretending to feel better because of her niceness? Like when she said she wanted to do the session, but then changed her mind when she was alone.
Well, yeah, she'd have to be the greatest actress in the world to mimic uncontrollable laughter. And when she came back in 2 weeks, actually, I didn't recognize her. Her appearance had actually changed, and I introduced myself. She was all dressed up. I don't mean to be sexist. I probably am old and sexist, but you saw that she was dressed rather drably, and sometimes the external reflects the internal. And she was, as I say, extraordinarily severely depressed. And when she came back, she was smiling and joyous, and she'd been on a kind of a crash diet, but she looked like a cover girl for cover lady for Cosmopolitan magazine or something. And uh, and she said, "Don't you recognize me?" And I says, "No, I thought you were a new patient." She says, "Look at me. This is Terri." And I said, "Oh my God, you're Terri." But she wasn't just undepressed. She was jubilant, and she's been that way, as I say, for over 40 years, 30 years, 30, 40 years. Yeah.
What gave Dr. Burns the confidence to keep going over clients' protestations?
That's the way I am.
There's quite a few questions. Maybe this one's for you, Jill. Just how do you incorporate some of these techniques with telehealth, with video therapy?
Yeah, and one other thing I was just going to say when David said that's just the way I am.
Okay.
But also, I mean, David and I both like, we're not afraid of emotion. And in fact, we love emotion. I think that's why we do what we do. Like, that's what makes our work real. And so I'm not worried if a patient is highly anxious that that's going to be damaging, or that if a patient is sobbing, that that's going to last forever. And I think really having confidence that quite often, as David says, going to the gates of hell, experiencing intense emotions without avoidance is, such an important part of the healing process. And so I think it's that we don't have that fear that we're going to damage or hurt our patients. And I think that's what contributes a lot to that confidence. Sorry, Mike, your next question was about telehealth. The reason I put this one on is because someone asked for the discount code. So the discount code is at the bottom of this slide. So Mike, your question about telehealth. Yeah, I mean, I think you have to be creative. And Mike, you might even have comments too about this, and you're welcome to jump in too. But yeah, I will, if there's something that I can do with a patient online, if it were a dog phobia or a spider phobia, if there are things we can actually do together online. I was treating a patient who had a fear of in getting an injection, shots and stuff. And so actually what we ended up doing was finding a really fantastic video of like a phlebotomist training video, where we got to watch all sorts of videos about, needles and injections and things. And we did that during the session. So there are times you can be creative and do exposure in session with the patients. You can also recruit another person, like maybe there's a family member, and you can kind of teach them and tell them how to do the exposure with the patient. Otherwise, you have to have the patient doing it on their own. I know actually Richard Lamb, who works at Feeling Good Institute, said for social anxiety exposures, he'll have the patient have him on video on the phone. And then they'll go to the sort of like, let's say downtown, where they need to go talk to 5 people, and he'll have them talk to 5 people, and he'll kind of be in their pocket, so to speak. So yeah, there are ways that you need to kind of be creative to try to do this stuff on video therapy. But I will definitely do cognitive exposure with patients on video therapy, just as I would in person.
I just saw that the CE survey was the wrong link, so I'm just adding the correct one in here now.
So you guys, there's 2 links that Mike will be adding. One is the general public survey. There's just like 2 or 3 questions. If you're not a therapist, go ahead and do the general public survey. That's just asking you generally how the presentation was. If you're a therapist, please make sure you are doing the CE survey. So Mike, make sure you drop the CE survey in the chat.
Yes, I put the updated CE survey. The first time I did it gave both links as the same one. So the correct one is in there now. Thank you, Jill.
Yeah, so
maybe
yeah,
time for
click on that last one. If you're a therapist, make sure you're doing the CE survey.
maybe time for two more. One quick one. Somebody put, I feel like I've been taught everything wrong in therapy. My therapist is all about trying to regulate during moments of anxiety, stepping away, using breathing techniques to lessen the anxiety. And you're saying the opposite. Can you explain what I should do when I experience social anxiety, especially in a social context? I don't understand. Just let it happen with no calming.
You want to answer that, David?
Oh, I'll let you answer, because I didn't get the second part of it, but I sure resonated with the first part of it. I sometimes I'm elderly, so I'm irritable half the time now. It's horrible, so you should avoid me. But I get irritated when I hear about the kind of therapy a lot of people are doing, just the opposite of what we're teaching, and it frustrates me. But you can answer the second part. The second part.
Okay, and I just want to make sure people know that they want to do the CE survey. And so Mike you can even, Mike dropped it again. So make sure you're doing the CE survey. if you're a therapist, and it's a long survey, so you'll know you're on the right one. Yeah, the my answer in general is like I want people, there's a bit of a difference between I like to meditate or exercise or something like that to manage stress or because it feels good. I don't have a problem with that. That's, there are strategies people use to feel good and healthy and calm and grounded outside the context of like an acute fear or anxiety. I think the problem is when people rely on doing A, B, or C to not feel anxious in the moment. And why is that a problem? Number one, because it's like a crutch. That means every time I feel anxious, I have to do, hold my charm or say my mantra or do my deep breathing. I'm never actually cured of my anxiety. I'm just learning how to cope with my anxiety or how to stifle my anxiety in the moment. I also think that any reliance on something like that, like I must do X to get through it, kind of still sends you the message cognitively that I am not safe. I need to do this in order to be okay, versus building the ability to experience and tolerate anxiety and to know no matter what, like I could be incredibly anxious and I know I'm okay. I don't have to do anything to try to get rid of those feelings.
I think that's all we have time for today.
Yeah. So I guess what I will say then, let's say, is to say thank you to everyone for attending today. It was always an honor to present with David, to listen to these stories, no matter how many times I hear them. I love them. You're totally an inspiration to all of us, David. And thank you to Mike for helping facilitate with us today. And thanks to all of you for spending 2 hours with us. We hope to see you in a future training, and yeah, hope that we're contributing to your growth as a therapist or as a patient along the way.
Thank you, Jill. You've taught me tremendous things. I'm so grateful for knowing you and teaching with you. And Mike, I just love both of you. You're both fantastic, and I love and appreciate all of you for coming today. And thanks to Maor for sponsoring these free events. A lot of effort goes into them, and Jill and Maor and all the people at the Feeling Good Institute make these things possible. And so I just say thank you. It's just a fantastic 2 hours for me, and I hope all of you enjoyed yourself as well, and maybe learned a little something, and maybe got challenged to think in some new directions.
Thanks, and hope to see you guys soon.